Next, we move on from the brachial plexus a little higher up to the cervical plexus. So what are the indications do you think would be for cervical plexus? I've not listed them, so I will likely, but before that, what I'll do is I'll go through the anatomy, brief anatomy of cervical plexus. Then you can tell me the indications. Okay. So we all know it, superficial cervical plexus, deep plexus, there's nothing like that. It's all that there are deep plexus. Excuse me at the back, guys, please. Can you tell these guys? Hello, at the back. Either you go outside or because you're disturbing the. So there are actually superficial branches and deep branches. Okay, so we have actually named them as superficial cervical plexus and deep, but there isn't exactly like that. Okay. So if you look at the superficial branches, okay, they all come from the roots. They form like a loops. Okay, C1, C2, C3, C4. Okay, you got the lesser occipital nerve, greater auricular nerve, anterocutaneous nerve, and supraclavicular nerves. Okay. And to remember them, very easy. These are the deep ones. Sorry, these are the muscular ones. Okay. So again, the loops they give out the muscular branches. They also connect with the hypoglossal nerve. So cervical plexus connects with the hypoglossal nerve, and the other motor nerve which comes out from cervical plexus is the phrenic nerve, which we were discussing that it gets blocked in the interscalene block. There is something called ansa cervicalis. Anybody know what is ansa? Why is it called ansa? You know what does ansa mean? Ansa means necklace. Okay, so it's like a necklace. It hangs like a necklace. Okay, so it's called ansa. And it gives out quite a bit of muscular branches, which I'll show in a minute. There are obviously branches to the neck muscles and to the muscles of the tongue. You also get branches to the sternocleidomastoid and branch to the trapezius, levator, scapulae, and strainus medius as well. And one of the branches, it also communicates with the accessory spinal. Okay, and that's what you get when you actually go too posterior when you're doing interscalene. If you see trapezius, and then you get shrugging of the shoulder, and you think that you're in the wrong place, you're too posterior, and then if you inject there, you don't get a block. Okay, that is actually because you're blocking one of the muscular branches to the. This is the ansa. Ansa gives branches to your strap muscles of the neck. Okay, so that's the ansa cervicalis. Now, knowing the anatomy, okay, what it supplies. Now, can you tell me the indications? Can you guess the indications first? Thyroid surgery, you can. Okay, the leg for that. Clavicular plating, okay, supraclavicular nerves, okay. Carotid endopathy is the commonest indication for cervical plexus. Anything? You have to supplement that if you actually, instead of interscalene, if you have to go to supraclavicular area. The cape of the shoulder is supplied by the superficial cervical nerves. So then in that case, you have to do superficial cervical plexus block. Okay. Anything else? Sorry?
Pneumoperitoneum pain.
Pneumoperitoneum pain. You want to block the phrenic nerve then? Yes. Okay, it's an effort pain, isn't it? It's an effort pain, so I don't know how effective it is, but yes, you can try, but it is, yes. You can give for radical dissections then. You can also for subclavian cannulation or interjugular cannulation, you can just use superficial cervical plexus blocks as well in awake patients. Okay, there's the other thing. So there are a lot of indications, but this is one block which is never done because people are so afraid. Say, oh, we need to give a deep plexus block, or we need to do. But actually, I'm going to tell you about one very simple block, which people are not. Okay, so we know that there is something called the deep plexus and superficial plexus blocks. But there is something called intermediate plexus block. I think this is done here. Okay, right. What you see here is the investing fascia of the neck, right? When you deposit local anesthetic behind the posterior border of sternocleidomastoid under the skin and subcutaneous tissue, that is known as superficial cervical plexus block. You go at the root level, you hit the transverse process, come out, deposit local anesthetic there. That is deep plexus block. So if you look at the superficial nerves or the cutaneous nerves, okay, we see there are ascending nerves going up, there are transverse nerve, anticutaneous nerve, descending nerve, the supraclavicular nerves. Okay. So we have lesser occipital nerve, you got greater auricular nerve, these are ascending nerves. The descending one are supraclavicular, and one going anteriorly, the transverse cervical nerve. So all these nerves now, they are actually supplying the whole of head and neck cutaneously. So any surgery, whether you're doing cervical node biopsies, or you're doing parathyroid surgery, or you're doing any surgery on the neck, even carotid surgeries, okay, you can actually use. People are using it for pain. Well, lesser hospital doesn't supply that much, okay, but you can actually apply that. You can actually use for some of the surgeries on the ear as well. So that is very simple block. Okay, so you mark the posterior border of the sternocleidomastoid. From midpoint, you go put local anesthetic on the posterior border, and you've done the superficial cervical plexus block. There are people who actually do all of carotid surgery just with superficial cervical blocks. If the patient feels more pain, they will ask the surgeon to infiltrate. But yes, you can actually do whole awake carotid surgeries with just superficial cervical plexus block. But much better than that is another block. This is just showing the area where we will do that. Now the deep blocks. Now deep blocks, it's so complex in our final FRCA. They ask us about these blocks. Okay, cervical plexus block is there. Okay, you have to describe. Oh, the landmarks are actually, you feel for the mastoid, and you feel for the chest neck tubercle. Chest neck tubercle is easily felt, that is a C6 tubercle. Okay, transverse process of that. You mark the line, and you actually draw a second line going through C2, C3, C4, actually, and then go and deposit local anesthetic at each level. You can do it at levels, or you can go at C4 level. C4 level is the important level here. Okay, so you feel for the thyroid notch and draw the lines across, and that is C4 level, whereas the cricothyroid notch, that is C6 level. Okay, that was no superficial cervical plexus block. This is not deep cervical plexus block. Now we're going to show a video of a superficial cervical and a intermediate cervical plexus block. So deep cervical plexus block is complex. Okay, now if you actually do a intermediate cervical plexus block, you can actually do all the surgery on the neck. You can actually operate on the muscles of the neck. So you can dissect. You can actually go deeper because the local anesthetic actually seeps to the roots. And if you have time, if you're impatient, you can actually combine the intermediate with superficial cervical plexus block, which is I'm going to show in the video. But if you have got time, you can just actually do the whole surgery just with intermediate cervical plexus block. The landmarks are the same. It's a midpoint of the posterior border of sternocleidomastoid. Okay. So I mark the posterior border of sternocleidomastoid. Okay, the midpoint of that. You can see the external jugular actually going there. Okay. Take a needle, go through the skin, and once you go through the skin, you feel the bounce on the investing fascia of the neck. Okay. As you go through that, you're going to feel a little pop. Okay. So this is the first of the pop needle. Bounce and pop. Our pop hero is not there, Surjit. Okay. So here you do that and you inject local anesthetic. You just need around 15 mLs. If you want to inject 20 mLs, you can. But 15 mLs are usually enough. And once, if you actually want the surgeon is sitting on your head, jumping on your head, you can actually do the superficial as well. So I went up along the posterior border from the same puncture point. Okay, so you can actually do both superficial and the intermediate cervical plexus block. Okay, so how many of you actually have done these blocks? Intermediate? We started doing now. Yeah, okay, so that is a new block for people who haven't actually seen that. Okay, so go and do it. For neck surgeries, for this, one of the greatest advantage of the intermediate cervical plexus block is that you can get away without actually doing a phrenic nerve block like you do with the deep plexus. So you can actually do awake surgeries even on parathyroids, on thyroid surgeries. You have got a high-risk cases. You're afraid to manipulate the neck. You are afraid to actually manipulate the airways. You want to actually do that. High-risk cases can be done. You have got patients who actually need a center line, subclavian. Just do a superficial cervical plexus block. Okay, you will be fine. Okay, any questions? For the intermediate cervical plexus block, if you're doing as a sole block, you don't need more than 15 mLs. So with 20 ml syringe, you can actually do the whole block. So you get 15 mLs, do the intermediate plexus block, come out, and 5 mLs across the border. Okay. So 12 to 15 mLs for that, and 5 to 7 mLs along the posterior border. You can do it.
Any spray towards other
No, that is the thing. This is a very safe block. But you have to remember that if you are going deep, that means you've already popped. When we talk about loss of resistance, we talk about something called cushion effect. Okay, you can. So you could actually have popped the fascia, investing fascia when you were going through the skin. So you need to come out to the skin and go again, or follow the techniques we will describe in loss of resistance block. You don't want to go deep. Even the cervical plexus are not very deep at all. Okay, so you could be actually going in. So be careful. You need to be very superficial. Go through the skin. Okay, you come out again to the skin. Go feel a bounce on the fascia. Feel a pump. Deposit local anesthetic there. You're done.
what concentration do you usually use not more than 0.25%?
Yeah, we actually, the local anesthetic we use is levopitvecin. We use a combination of 0.25 and 0.5. You can use bupivacaine, you can use ropivacaine. With 0.5%, because you will still be within safe limits, you can 20 mLs, you can, but you're going both sides, then you have to be careful if you're doing both sides. Yeah, absolutely, yeah. With 15 mLs, 12 to 15 mLs, you never reach a phrenic nerve with intermediate. And if you go deep, like say, you have to be careful when you don't go deep and inject into the deep investing fascia. Then you do the muco, you will cause.
When we are doing it with USG, even with 5 ml, we can see the local going all the way to the IVC.
Yeah.
Inferior medial.
Yeah.
So that time we may block the phrenic also.
If you're not, you get with the intermediate, you can actually go, and that is one of the advantage because local anesthetic seeps towards the capillary sheath. And that is one of the blocks. Some people actually do it deliberately with the ultrasound. They do it deliberately. They will go to the sheath and deposit local anesthetic.
That time we just keep our concentration lower than 125.
Yeah, we can. Yeah. I mean, this is muscle. You're not actually. A lot of surgeries don't cut through the muscle actually. They tend to separate out rather than cutting the muscle. So yes, you can get away with a low concentration. 0.375 is a mixture because it's a mixture. You don't get as much motor blockade. Rather, it's not too less a concentration. It's a great mixture actually to have. Yeah. They don't produce it though.
We can produce it.
Yeah.
We can make it.
We'll make it ourselves.